there's a lot of information to go over, obviously, and so I wanted to try and make it as sort of nuts and bolts as possible, but also wanted to make sure that questions were answered. Normally, I like to have more of an interactive talk, but I recognize that that's impossible over Zoom. With that said, as I go through these slides, if you have any particular questions, please type them into the chat. And then I have a couple pause points where we can review that and discuss before moving on to other sections. I also received a list of questions that Dr. Fisher provided me yesterday that I've addended to the end of the talk and go through. I will try and get to all of those as well and answer the questions that can be answered at this point. I originally wanted to title my talk, When There Is No Intensivist, or Is There a Doctor in This ICU? But I feel that's a little bit draconian. So instead it's nuts and bolts, keep calm, and bend the curve. Speaking of the ICU and the staffing model, I'll get to that for a moment, in a moment. But first, let's remember that by failing to prepare, you are preparing to fail. And that is Ben Franklin quote, one of the good ones. The concept of our ICU running out of intensivists or intensively minded individuals is difficult to fathom. I think we have a very deep bench at this point, so I don't think we'll reach a point where we have no physicians in the ICU. But if we get close, we do have a plan in place for that. The Society of Critical Care Medicine has put out a tiered staffing strategy for pandemic coverage. This is a scary graph. It shows only one intensive care trained MD above, followed by 4 hospitalists or other non-ICU physicians, followed by respiratory therapists, PAs, residents, CRNAs here, ICU nurses, and then non-ICU nurses below. And this is really designed, in a true crisis situation where one ICU doctor would be caring for close to 100 patients. Our system, in the way that we have created a tiered structure for staffing, encompasses both attendings, residents, PAs, fellows, and both critical care and non-critical care attendings. The current model is 4 teams rotating Q4 with a night float intern, as you all know, and a PA team. We have a couple contingency plans that we've worked on with the chiefs, as well as a crisis plan. So our first contingency plan is to add another float team, similar to what the PA team is like. And this is from a resident perspective. From an attending perspective, we will be adding extra coverage as well. Contingency B would be to add a second night resident who would act as a float overnight, increasing the resident coverage to 3. Both the on-call resident, a second night float only resident, and then also, of course, the night float intern who's present. In the crisis situation, and that means multiple patients, high severity of illness, as well as increased numbers and admissions, we plan to dissolve the Q4 call, but remain with the resident numbers we have, plus these float teams above. Each CCAR would then admit daily to balance out each team, and we would not have that inequality of teams based on their call schedule. We can increase and add additional teams, not just one float team, but multiple float teams as necessary, covered by the fellow, supervised by fellows, PAs, and then covered by attendings as well. We would consider, changing to more of a geographic strategy, which we may do because some units will become more COVID heavy with increased COVID patients. And we've identified multiple units within the CCC building that can be converted to ICU care. Ultimately, there's also certainly a consideration for alternative residents as well as alternative attendings, and that would be anesthesia residents, surgical residents, neurology residents, those who are interested in critical care as well. So again, as I said before, I think we do have a deep bench, even taking into account those who might become ill or quarantined. So what I wanted to talk about today was, again, the nuts and bolts of critical care management. Briefly mention the COVID clinical course as it's known, and then dig into some vent management 101, some low tidal volume ventilation management, prone positioning, and then a brief comment and discussion about how we will respond to codes on COVID patients, and finally answer the questions that I previously received. So the clinical course of COVID is becoming more and more clear. And at any point in any of these phases, of which 5 have been described, as you all know, many of the patients do not progress to the 2nd, 3rd, 4th, or 5th phase. In fact, one of the great unknowns at this time is how many are in phase 1, or even phase 0, maybe, where they have minimal or 0 symptoms and don't recognize that they're sick. But as I'm sure you all are aware, phase 1 is more of a prodrome phase. There's a low-grade fever, some cough, and this usually, without desaturation, this usually takes place at home. Phase 2 can be thought of as sort of a slow smoldering phase, with what's described as silent hypoxia. These patients are admitted to the hospital, and they receive a few liters nasal cannula oxygen, but during that time period do not appear to be in any acute distress. They are hypoxic, they require extra oxygen, they require symptomatic care, but appear to be generally well. Phase 3 is where things might take a turn for the worse. And at this point, there's a clinical decline, the rapidity of which varies. It can be hours to days, but generally relates to an increasing amount of oxygen requirement that patients require, and can happen somewhat abruptly. And it is at this time that we really want to consider transfer to the ICU to prepare for further management and possible intervention. Dr. Vinayak has worked with groups through, groups within MedStar and across the MedStar system to create a clinical guide for assessment of severity and also for triage purposes. This is available on Starport, as are all of the different guidelines and protocols that we've been creating. But I wanted to focus only on this specific severe risk group, as this is the group that it's recommended it has an evaluation for or admission to the ICU. This can be from the emergency department or hospital wards, and it primarily relates to hypoxia or worsening respiratory rate, tachypnea, or work of breathing. There is a modified CURB 65, which is the CURB 60, that you can see here. And if there's 3 or more of the following present, just as this might recommend admission for pneumonia, it also recommends higher level of care for patients with COVID positivity. To summarize that a little bit more clearly, in early transfer to the ICU is better. And we recommend and identify patients early on if they have a increase in oxygen requirement by nasal cannula by 50% in 12 hours, if their respiratory rate is over 25, if they have hypoxemia that requires greater than 6 liters to maintain an oxygen saturation over 94%, or a P to F ratio of less than 300. Again, also another reason for admission to the ICU may be if they meet these 3 criteria on the modified CURB 65. What we've seen so far, however, is that many patients will meet the criteria for ICU transfer based on increasing oxygen requirement alone. So that's phase 3. Phase 4 is classified as respiratory collapse. And I want to again mention that many patients will stay in phase 1, phase 2, phase 3, may need to be stepped up to the ICU, but ultimately not move into phase 4. And it's unclear what predicts that that occurrence. But phase 4 is respiratory collapse and is classified as a substantially increased oxygen requirement. We have decided to not utilize non-invasive ventilation, although other centers have, because of the aerosolizing potential of positive pressure. We are limiting high flow nasal cannula to 25 liters per minute at 100%. And when a patient is on high flow nasal cannula, we recommend using a non-rebreather mask that is tight fitting, again, to try and reduce aerosolization. There is a recommendation for early and controlled intubation with all providers wearing N95 PPE in the ICU if possible. And the reason for that is that we want to try and have as much of a control over any procedures performed on these patients as possible, given this very high risk of aerosolization and very high risk of exposure of respiratory droplets to healthcare providers. Once the patient is intubated, the idea is to initiate ARDS protocol for ventilation. And I want to speak a little bit about ventilation in general and the nuts and bolts of ventilation next. Our ICU has the Maquette Servo U ventilator, and that's what our screen looks like. However, we have a total of 85 vents here at Georgetown ready to be deployed. Our limitation is not ventilators at this time, it's space currently. But as mentioned, we are actively retrofitting many of our ICUs or units in the CCC building to become ICUs. The ventilators that we have, I don't believe we have all 80. I don't believe all of our 85 ventilators are the Servo U, but the general principles of ventilators applies to all of them. This is a little basic, but I wanted to go through it. And I feel it's probably appropriate, given that I was speaking to a friend of mine recently who's been a practicing endocrinologist as long as I've been a practicing pulmonary critical care doctor. And when we were talking about ventilator management, she laughed out loud when I said PEEP. And she said, "Oh, PEEP, that's something I haven't thought about in years. I don't even remember what that means." So I think this is a good refresher for everyone. So ventilator management 101. So the ventilator acts as support when the lungs fail. It assists in both oxygenation and ventilation. And ventilation, remember, removes carbon dioxide via tidal volume and respiratory rate. So increasing tidal volume, increasing respiratory rate will both increase that ventilation and remove more carbon dioxide. Oxygenation can be improved by increasing the FiO2 and increasing positive and expiratory pressure. And the ventilator can be adjusted to maintain appropriate pH, PCO2, and PO2. And our changes to the ventilator can often be guided by the ABG as well as oxygen saturation on the monitor, along with different pressures that we're seeing that the ventilator is needing to provide. There are basically 3 important modes of ventilation. There's assist control, volume control, and that's the mode we use for ARDS. There's also pressure regulated volume control, or PRVC, which is the mode that we use as a default for patients with normal compliance and non-hypoxic patients. There's also pressure support, which is primarily a mode to evaluate for extubation. Assist control volume control, this is the original mode of mechanical ventilation. It can also be called CMV, or continuous mechanical ventilation, or controlled mechanical ventilation. And it can also be called assist control, or AC alone. ACVC, or assist control volume control, just distinguishes it from pressure control, which is an alternative mode that is not utilized as often in this country. Assist control allows you to give an exact tidal volume that you've set and allows for exact measurements of important pressures that we're interested in with patients with ARDS. It is not as comfortable as patients as PRVC, supposedly, and therefore PRVC is utilized more often. The pressure is regulated to give the same amount of volume, but the pressure is regulated based on the flow, and it's thought to improve comfort for patients. That comfort, though, comes at the expense of not controlling the tidal volume exactly, which we feel is very important in treatment of ARDS. As I mentioned, it's our default mode of ventilation, but we switch to AC when we're treating with the ARDS protocol. Remember that there are 4 traditional settings in assist control. There's the tidal volume, and I want to emphasize that we should always consider the ideal body weight when we set the tidal volume. The respiratory rate, which is usually between 10 and 16, but can be up to 35 in the ARDS-NET protocol. FiO2, which is the percentage of oxygen, can be set between 40 and 100%. And then PEEP, which is positive end expiratory pressure, and that is 5 and set up to usually at a minimum of 5 and can go up to 24 in the ARDS protocol, but usually is set between 5 and 14. So just a word on PEEP. It is not just a tasty treat consumed this time of year. It does stand for positive end expiratory pressure. And what it does is it improves oxygenation by increasing the volume in the lungs at end expiration, which allows for more alveolar recruitment. It basically, by giving PEEP, when you've exhaled, you still have an increased amount of volume in your lungs, which exposes the alveoli to gas for longer. Which allows for more gas exchange, and subsequently you see an improvement in oxygenation. A PEEP of 5 is the minimum setting, and this is generally thought to restore the resting lung volume at end exhalation more towards normal. The resting lung volume at end exhalation is also called the functional residual capacity, which you can see here on this graph. And therefore, giving PEEP increases that functional residual capacity, which recruits alveoli. Just to summarize this graph quickly, this graph might be one that you all remember clearly from medical school. It is the respiratory, it's the compliance of the respiratory system. You see that this is where you separate out the chest wall and look at the compliance of the chest wall, and then you take out the lungs and you look at the compliance of the lungs here, and then what you see is a balance between the lungs and the chest. And this demonstrates that compliance here. There is an equilibrium point, as you can see here in the middle, which relates to a pressure of 0. That equilibrium point is the equilibrium point that we reach when we breathe relaxed at tidal volume. I take a breath in, and my volume goes up, and then I take a breath, and then I passively allow that volume to exhale, and I reach this point of equilibrium, which is FRC, or functional residual capacity. When I give PEEP, and this is the important point, I'm increasing my pressure here, across here, maybe to 5 from 10. What that does is it actually moves this equilibrium point up on this curve of compliance of the respiratory system, and also sets that FRC at a higher point, which allows for more gas to be in the lungs throughout the entire respiratory cycle, again, recruiting alveoli and improving oxygenation. So assist control, it allows setting our 4 traditional settings of tidal volume, respiratory rate, FiO2, and PEEP. It provides data about a patient's response to the ventilator and how severe their disease is based on the pressure measurements and compliance. So we can really interpret how a patient is responding to the ventilator based on what information the ventilator is providing to us. It also allows us to make small changes in tidal volume, small changes in respiratory rate, to help protect the lungs from further damage while we support the lungs. And it also allows us to measure clearly the peak pressure and the plateau pressure. So again, this might be a graph that you've seen before. This is a graph of airway pressure up and down here, as well as over time. And you see that over time, time is passing, the patient is at positive end expiratory pressure, and then there's a pressure that is given to drive the breath into the lung. At the top, you reach end expiratory pressure, which is a peak pressure, the peak pressure here. Then you can put in a pause, and a pause will drop that pressure down to what's called the plateau pressure. What you can see over here is that the pressure that is required to give that volume is a combination of the pressure needed to overcome the compliance of the lung, how hard it is to open the lung up, as well as the resistance. When you stop the flow after the full volume has gone in, then you sort of subtract the resistance. The pressure that's required to overcome the resistance of the airways is removed. And the only pressure that's left is the pressure that is required to keep that volume in the lung. In ARDS, that is the pressure we care about the most, because that pressure, the pressure that is needed to keep that volume in the lung, is the best approximation that we have to alveolar pressure. And when we think about ARDS net and we think about protecting the lung while ventilating, we care most about what the pressure is that the lung parenchyma and the alveoli are seeing. And therefore we care about and we talk about that plateau pressure right here. So I want to pause for just a moment, Ernest, if there's any burning questions that have popped up so far. I'd love to chat about them, and I'm happy to go over any of those graphs again about, sort of ventilator 101.
Yeah, there was one question that I think was answered, but just so maybe everyone that's not on the chat can hear it. It was about when you're in AC mode, is that a mode that will require the patient to be paralyzed?
That's a great question. No. So I think that that goes into the a little bit about ARDS net, but when we use PRVC or AC, truthfully, many patients will tolerate both of those modes quite well, and they can require very little, if any, sedation. And our general goal in the ICU is to use as little sedation as possible to allow patients to interact, to use their muscles, and even to work with physical therapy while still on the ventilator. The difference between standard ventilation and ARDS net ventilation is that we are doing various things with the ARDS protocol to protect the lung, which also does not allow the patient to breathe as normally as they would like. For example, we target lower tidal volumes, and lower tidal volumes would mean that a patient would want a higher tidal volume, but we're not giving it to them. So that can cause distress and cause them to have vent dysynchrony or agitation. Also, we may reduce their tidal volume and their respiratory rate in such a way that their carbon dioxide increases, causing permissive hypercapnia. This is a very uncomfortable situation to be in for a patient because their body wants them to have normal capnia. And so they will, again, struggle with the ventilator, struggle with attempting to take deep breaths, breath stacking, and agitation. So to prevent the patient from experiencing that discomfort, increased sedation is often necessary and appropriate. What we want to do is take away the patient's ability to take those deep breaths so that we can, or increase their respiratory rate so that we can truly control and protect their lungs while they remain injured, and not cause the ventilator to, not allow the ventilator to cause any further damage. There are times when patients, even with substantial sedation, still remain quite dysynchronous on the ventilator. And in that situation is when one would consider paralysis. Any other questions? Okay, so then I will move on. I just wanted to make sure we plugged in some of these so we don't wait till the end for all the questions. So interestingly, the COVID virus causes what appears to be an ARDS-like picture in patients' lungs. And that means that it's acute in onset. There is bilateral infiltrates that are seen. They are not associated with heart failure or other causes, and it is associated with some profound hypoxia. Because of that, we are electing to treat all of these patients as we would anyone with ARDS. And that means focusing on lung protective ventilation. To think about ARDS and why we do lung protective ventilation, I think it's useful to think about the latex balloon versus the leather ball. Primarily, the latex balloon can be thought of as our own lungs. It is easy to insufflate them with air. You do not require a lot of pressure to do that. On the other hand, a leather ball, when you were to try and blow that up and improve, and cause increased volume in that ball, that would require a lot more pressure. And therefore that ball can be thought of as having worse compliance. This, you can see this when you look at these chest x-rays, a normal chest x-ray, normal compliance, latex balloon versus a lung that is full of alveolar infiltrates. This causes the lung to need more pressure to give the same amount of volume. And that's just like the leather ball. You can think that this makes sense based on thinking about what's actually happening in the lungs, right? The alveoli are filling with fluid. There's capillary leak. Also, the interstitium there's inflammatory cells there. It is thickening as well. And both of those things cause the lung to not be as compliant and therefore need more pressure to give the amount of volume that you want to give. Again, I referenced this graph here, which is the medical school version where you're removing the chest wall and removing the lungs and looking at the balance between them. In the ICU, we often mostly focus on this graph here, which is volume over pressure. And again, that's volume over pressure. So this is the compliance curve. This can be thought of as just this small section here, where it really relates mostly to our tidal volume before, above and below, and a little bit of above and below. And what you can see is with increased or normal compliance here in the middle, which is we all have, it's a relatively straight line in the area that we would be providing ventilation. But in patients with decreased compliance, and what this really means is that for the amount of pressure needed, you need more pressure per amount of volume than here where you give less pressure with the same amount of volume. With this decreased compliance curve, what you can see is that there's areas where there are less compliant areas at the bottom here or at the top here, and then more compliant areas here. And we've found that if you try and ventilate only in this best compliant area or more compliant area, do you get a benefit and a reduction in the injuries that might occur from the ventilator. These injuries occur, as I described, at the bottom here and at the top here. And what that is down here you get atelectasis, and the lungs are collapsing. You can see that in this picture of explanted animal lungs. With low volume, actually see these areas of atelectasis that can develop. And what happens is when you open and close those alveoli, the forces that are required to open and close those alveoli are much greater than the force to hold the alveoli open and just increase the volume in the alveoli. So what's happening down here and why there is a lower compliance in that area is because those alveoli are opening and closing, opening and closing. The opening and closing of the alveoli also cause damage. There's shear forces that occur, there's disruption of the surfactant layer, and there can be microscopic and macroscopic damage to the lung from opening and closing at that lower volume. Along the same lines, there's damage that can occur at the top of this compliance curve, and that's from overdistension. You can see that here, where both volutrauma and barotrauma can occur, causing microscopic and macroscopic injury to the lung. Now, of course, the injury to the lung that we're seeing with ARDS or with COVID positivity is one concern. But then with the ventilator, if the ventilator is ventilating patients down here or up here, there's worsening injury to the lung, which compounds the problem. You compound the issue where you have an increase in capillary leak, an increase in inflammation in the lungs, and it makes things worse, not better. So stealing this slide directly from Dr. Vinayak, this is what we can see from, sort of a graphical representation of what we attempt to do. So we try and avoid that alveolar collapse down here, and we try and avoid the alveolar overdistension here, and ventilate only those, only within this area of the compliance curve, utilizing pressure as through the use of PEEP to start our breath here, and then using a lower tidal volume to not reach up into this area. So lower tidal volume, increased PEEP will allow us to be in this part of the curve. So that's the principle behind why we ventilate the way we ventilate in low tidal volume ventilation, or the ARDS-NET protocol. The goal is to avoid high tidal volumes and high plateaus, to use PEEP to prevent lung collapse and improve oxygenation, and then allow for permissive hypercapnia if you need to reduce the plateau or reduce the tidal volume. And that would mean that, a normal tidal volume might go up in this area, but if we need to avoid this area of overdistension, we could reduce the tidal volume in such a way that would allow us to ventilate only in this area at the expense of normal carbia. And allowing for some hypercarbia is acceptable, given that it allows us to protect the lungs as best we can.
Hey, Dan.
Yeah.
Just along that line, there's a question about what level of hypercapnia and maybe what pH you would allow before you would make a change.
Absolutely. So I'm going to go into that in the next couple of slides, because I wanted to really give the actual protocol, so that if we're all at the bedside and whoever's there can make those changes and talk with the respiratory therapist about that. So I'll get into that. But that's a great question.
Okay, and then this was kind of touched on at the beginning, but in terms of why we've jumped from the high flow to intubation, what was the reason not to have an intermediate step?
Absolutely. So we've discussed that, and it's a great question, because in the past, and over the last decade, we have really seen an increase in our use of high flow nasal cannula and non-invasive ventilation as a way of staving off true positive pressure ventilation and mechanical ventilation. There's a lot of good reasons why that might be beneficial. A patient who is utilizing non-invasive ventilation remains awake. They're not sedated. They're able to interact. And we've seen that those patients may be able to not, even those who develop multifocal pneumonia or ARDS may not require intubation, may be able to be maintained on non-invasive ventilation for a few days and then come off. And we've seen that. And the utility of high flow nasal cannula has really even added an increased benefit to that approach, where you can provide that increased amount of oxygen in such a way that really trying to avoid mechanical ventilation has been a goal. The problem with this disease process, and what we know so far about patients who are infected with COVID-19, is that once they've developed once they've entered that phase 4 where they have respiratory collapse, or phase 3, there appears to be a point at which the process is ongoing, that there's no plateau, and therefore intubation is going to be inevitable. And should subsequently be done in a more controlled, in as controlled of a nature as possible. So that partly has to do with the fact that it appears that the disease process is one that is ongoing and does not plateau, and also because there is a real and significant risk of aerosolizing viral particles and virus from patients when they are put on non-invasive ventilation. So for that reason, at the time being, we have opted to utilize high flow nasal cannula, but only up to 25 liters per minute of flow, and not to use non-invasive ventilation. This is based on data out of China as well as Seattle, where if a patient reaches the point where non-invasive ventilation might be necessary, then intubation should be planned for. Okay, so going through the ARDS-NET protocol, and I want to draw your attention to the bottom of this slide here, where I just say Google ARDS-NET PDFs, and that's what these are from. The ARDS-NET was a clinical network. It's now been supplanted by something called the PEDAL network, which started with a blockbuster study, which was the low tidal volume ventilation study published in 2001. It was followed by a bunch of other studies that were did not hit the primary endpoint as out of the park as this one did with regards to mortality, but were very thought-provoking and had a lot of positive secondary endpoints. Nevertheless, this was the study that we refer, when we talk about ARDSnet, we really are referring to this, and the ARDS protocol is from this study. Our ARDS protocol at Georgetown is exactly the same as the protocol that was done in the study. And this data that I'm showing you here is from these PDFs. So let's go through it in detail, because I think it's important for us to understand not just the pathophysiology and the reason for why we utilize low tidal volume ventilation, but what the nuts and bolts are. What are we actually going to do? So first, you want to calculate the patient's predicted body weight or ideal body weight. And this goes to the concept of the fact that our lungs do not change with our body habitus. So if a patient is, has a body weight that is 300 pounds, their lungs will be the same size as if they were 130 pounds. And so the predicted body weight or ideal body weight calculation is based on gender and height alone. If you Google ARDSnet PDFs, a table of height, gender, and then predicted body weight tidal volumes will come up. What this means is that we should really be talking about patients' tidal volumes not in terms of absolute number, but in terms of what is their cc's per kg of ideal body weight. And our goal is 4 to 6 cc's per kg, or mLs per kg, as you can see here. But it requires first an appropriate measurement of their ideal body weight. The ARDSnet said select any ventilator mode. We use assist control, volume control. Other countries use assist control, pressure control. It actually doesn't matter. But from our perspective, we use assist control, volume control. The initial settings can be up to 8 cc's per kg. But then you want to relatively quickly, at intervals of less than 2 hours, bring down that tidal volume to at least 6 mLs per kg. You then want to set the initial rate to approximate the baseline minute ventilation. So if the patient was breathing relatively quickly, then you would want to set a relatively quick respiratory rate. Either of these things, no matter what you choose to do and whatever respiratory rate you choose to set, you're going to alter that based on the arterial blood gas that you obtain within 20 minutes to a half hour of these initial settings. Then you're going to adjust the tidal volume and the respiratory rate to achieve the pH and plateau pressure goals as described. So your oxygenation goal, our normal oxygen right now is approximately 100 millimeters of mercury, PaO2. The goal for ARDSnet is 55 to 80. So as long as you're within that range, you don't need to make a change with oxygen. Okay. If you go below 55, obviously you want to increase it. If you go above 80, you can decrease it. But if it's within that range, you keep it where it is. You can adjust the oxygen for ventilation on the ventilator based on the ABG or on the SAT from the SAT on the monitor. And the saturation on the monitor can be between 88 and 95%. So we're tolerating a little bit more hypoxia here than one would generally be comfortable with, but it's felt to be acceptable. As I mentioned before, you want to use a minimum PEEP of 5, and then you can consider this use of these PEEP FiO2 tables that they're describing here to achieve your goals of oxygenation. I will show you those PEEP FiO2 tables because I think they're very instructive, and they are incorporated into our protocol at Georgetown. Your plateau pressure goal is less than 30. Remember, I described the peak pressure and the plateau pressure, and really we focus on the plateau pressure here because of that the understanding that that's the best approximation of the pressure that the alveoli are experiencing. You want to check this plateau pressure at least every 4 hours, and then also after each change in PEEP or tidal volume. You can understand the understanding is that the plateau pressure is affected by both the PEEP and the tidal volume. If you have a PEEP that's increased, the plateau pressure will increase. If you have a tidal volume that's increased, the plateau pressure will increase. It is also affected by the compliance of the patient. If the patient has poor compliance, then the plateau pressure will be higher. It will require more pressure to give that tidal volume. Remember that the compliance is a measure of how how sick the lungs are, if you will, or how how full of fluid and the interstitial pneumonia, interstitial process is present. Therefore, as a patient improves, their compliance might also improve. If their compliance improves, then their plateau pressure will come down from that reason. For that reason, vice versa, the opposite would be if they worsen, then their compliance will worsen and their plateau pressure might increase. So it's something we want to watch every 4 hours because it's a dynamic measure. Our goal is to reduce that pressure to below 30. If the pressure is over 30, then you can decrease the tidal volume, and you do that by 1 ml per kg steps to a minimum of 4 mLs per kg, which is a low tidal volume. If the plateau pressure is less than 25 and the tidal volume is less than 6, you can increase the tidal volume. And again, you can increase it up to by 1 per kg at each time. And you do that because although 4 is low and it might be ideal, there is a recognition that staying at 4 when the plateau pressure is low is probably unnecessary, given that there are side effects of staying at a low tidal volume. Those side effects being significant patient discomfort and subsequent need for significant sedation, as well as hypercapnia. If there is a plateau pressure that is less than 30 and patient remains dysynchronous, you can consider increasing the tidal volume even higher, as long as the plateau pressure remains 30. So that's sort of a very important number to remember, that our goal, and if you are meeting ARDS-NET criteria, the goal is that your plateau pressure is less than 30. For pH, that was mentioned as well. So pH is controlled by controlling the level of hypercapnia. Our goal is 7.3 to 7.45. We tolerate down to 7.25 generally. If it is lower than that, you can increase the respiratory rate, and the respiratory rate can be increased to a max of 35. Again, the goal is to bring down the PCO2 to help buffer and bring up the pH, and that can be done by either the respiratory rate increase or an increase in tidal volume. Generally, we want to avoid increasing the tidal volume unless the pH drops very low, in which case you can increase the tidal volume to try and improve that. If that's the case, then the plateau pressure might go above 30, which is unfortunate but may be necessary. If it does go above 30, then we would feel that we are not meeting the ARDS-NET criteria, and we want to consider what is the problem, what other things can we do to try and help protect the lungs. Conversely, if the pH is too high, then you can decrease the ventilatory rate as well. So when we're rounding on these patients in the ICU, and what I ask the residents to report are some of the following, and I think this is an important aspect of care of these patients. If we were to reach a point where we had many non-critically care trained physicians caring for these patients above and beyond residents, we would really, to really focus on patients who are on the ARDS-NET protocol, we want not just their tidal volume, respiratory rate, FiO2, and PEEP, but rather what is happening, how is the patient interacting with the ventilator. So for example, a tidal volume, not just in total mLs, but what is the cc per kg? So we're at 6 cc's per kg, we're at 7 cc's per kg. What is the peak and plateau pressure for each patient? Again, our goal is less than 30 for plateau pressure. And then we want to know that we're able to follow the ARDS protocol for vent adjustments. The ABG goals are as I mentioned. This is from the MGUH protocol that is on Starport currently, and it describes similar goals to meet. Just briefly about the PEEP tables. So when moving up or down the ventilator, or increasing or decreasing settings on the ventilator, we want to recognize that ARDS and the hypoxia from ARDS, it often responds well to PEEP, and that increasing that end expiratory pressure to increase that end expiratory volume. What we're seeing in patients who are COVID positive is a substantial improvement with PEEP. That these patients don't have as significant decrease in compliance, but their hypoxia is profound and responds to PEEP. There's a lower PEEP table and a higher PEEP table. Both show decrements that you would move through. Things to remember are that if you're at 50% in the lower PEEP table, 50% of FiO2, your PEEP should be 10, okay? So if your ARDS-NET protocol, low tidal volume ventilation protocol, then the patient really should have much more PEEP than we normally give. PEEP of 10 at 50%, often if they're at 50% and they're not, they don't have ARDS, will probably be more at 5 of PEEP. At the higher PEEP table, that's even more profound, right? 50% would be 16 of PEEP. That's very high, and often it's difficult to get there because, again, as we increase the PEEP, the plateau may increase, and we want to keep that plateau less than 30. Another thing to note from these tables is that the maximum PEEP is 24, that we would not go above 24, but that 24 is actually quite a high PEEP number compared to what we generally utilize. So I'll take a moment there before talking more about adjunctive therapies, if anybody has any specific questions about the nuts and bolts of ARDS management. Ernest.
Hey, yeah, so I think there's a couple of questions, and I think Ajit wanted to comment as well about, maybe what's the ideal way to use ABGs to go through this protocol?
Yeah. The protocol suggests that we check an ABG every 4 hours at least and make changes at that time. I find that sometimes we make changes a little bit faster than that, and then we'll check an ABG after that occurs. The one thing I would caution is that PEEP also provides recruitment. It will recruit areas of lung that are not currently being utilized for ventilation. And if we are too fast with reduction of our PEEP because of our oxygen requirement, we may accidentally de-recruit parts of the lung. If we do that, then it takes a little while to recruit that lung again. And so every 4 hours with significant changes, I think is, once a patient is into a more stable range, is probably as quickly as we want to do that. But that's every 4 hours, day and night.
Dan, can I just add one thing? Chip and I, and we're all going to talk about this immediately, but we're going to try to minimize ABGs even now going forward, understanding that the expense and the resource utilization of those ABG cartridges may be really needed down the road. We're going to do a lot more end-tidal CO2 monitoring. So this excellent discussion. But going forward, I think we're going to really try to minimize that usual protocol, usual care, and focus on saturations and that target of 88 to 95%, and use end-tidal CO2 monitors, which maybe you can comment on, instead of ABGs as much as possible.
Do we have end-tidal CO2 for all of our rooms?
We have, I'll show you the numbers. We have, on the order of 3 dozen. And working, efforting for more.
I think that's great. And I think what Ajit is also referencing is that there's, just as the ARDS-NET protocol allows for using either the saturation on the monitor or the ABG, there are other ways to evaluate these measures. An end-tidal CO2 is not something that we have previously used, only recently have added it to our code response, but also have had the capability of utilizing it through monitor. So if we have that availability, it is the same process of making changes, but utilizing that in a measure from a non-invasive way. Looks like I'm running out of time a little bit, so I wanted to just go through a couple other things, primarily related to prone positioning and then also code response. So adjunctive therapy. So this is a classic chest X-ray of somebody with ARDS. They have bilateral infiltrates, but on CT scan, some of the areas are very much collapsed and not participating in gas exchange, and some areas are. And trying to balance that and improve that VQ matching is one of the reasons why prone positioning is thought to work. That also the ability of taking the mediastinum and the heart off the posterior aspects of the lung and having it fall more forward is another reason to put patients into prone positioning. This is again taken from the MedStar guidelines. But ultimately, what you want to do and think about with patients in prone positioning is that our patients, we do not have a rotoprone bed. We will position patients into the prone position and back to supine during daylight hours, and our goal is to have them prone 16 hours a day. We want to make sure that they're comfortable and also that their lines and tubes stay in place. So a deep sedation and or paralysis is appropriate. And care coordination is also key. Any procedures or interventions really should only be done when the patient is supine. And that includes chest X-rays, placements of lines, moving for studies, that sort of thing. There's a prone team that would assist with proning patients. There's an airway provider at the head of the bed who secures the endotracheal tube. And then it's been recommended for other individuals, 2 on each side, watching for lines, watching the monitor for decompensation. We may actually reduce that and see if we can reduce that number of people in the room even further. I do want to draw your attention to the video from the New England Journal that walks through the process, just to, even though our process might be different, just to recognize the pitfalls that are associated with that. There are potential complications as listed here. And when we discontinue, you either discontinue for clinical improvement, which is these numbers as well, or if there's complications that develop, primarily things like hemodynamic instability, but also if there's tubes that are removed or patients remain profoundly or develop profound hypoxia. I'm going to move forward a little bit further because I want to just mention code response as well. The patients who are critically ill, who have COVID in the ICU, as I mentioned, they have a relatively normal compliance even when they're quite hypoxic, and therefore they are PEEP responsive. We're seeing that they often initially present with single organ failure. They develop respiratory failure, they're hypoxic. Sometimes we'll see AKI developing, a mild transaminitis, and then some will develop shock. And the etiology of that shock is unclear, although it looks to be cardiogenic. And because of that, checking mixed venous O2 saturations, monitoring with point of care ultrasound is likely appropriate. So as I mentioned, there's 5 phases of COVID clinical course. You're not required to go through all 5, luckily. But phase 5 is either rapid death or steady resolution, and that's takes place in the ICU. The thought is that the progression towards death is associated with multi-organ system failure, and we've seen the hyperinflammatory response, cytokine storm that then results in multi-organ system failure, multiple pressors, and death from that. There's also a thought that there might be fulminant viral myocarditis that occurs that also precipitates malignant arrhythmias. That is if a patient progresses towards death. Obviously, many will not. And what's been seen is that there's a resolution over several days of this hypoxic respiratory failure with rapid return to near baseline extubation and discharge. However, there is a substantial mortality that we're seeing, this is from the study out of about 72,000 patients in China from about a month ago, And what it looked at is the case fatality rate, and it was described as 2.3% for all of the confirmed cases. This was heavily weighted towards more of the elderly patient population, and then those in critical care. So 49% who went to critical care. Also in terms of mortality from ARDS specifically in this study was 52.4%. So, only approximately 1% die, but unfortunately that 1% will die with us in our ICU. ARDS has a mortality rate of 40%. In the pre-COVID era, all comers, it ranges based on mild, moderate, and severe. And as I mentioned, the mortality of in patients with COVID positivity is 52.4%. So when patients come to our ICU, they have a very high mortality, and if you add on to that their age and other comorbidities, it is very appropriate, and we are very thankful for the palliative care team to be to have stepped up and become much more engaged. Because of this, it's imperative for us to have a conversation about code status with families, and have that conversation early, if possible, including the patient. To sort of have an understanding of what we might be facing. Our code response in the ICU and throughout the hospital is changed slightly from before. The protection of healthcare providers is paramount, and because of that, we have N95 PPE coming from 3 different locations. Every floor that has a code card and an inpatient exposure has a code pack of N95 PPE for the first responders. And that usually includes the respiratory therapist and the bedside nurse. When we respond to codes, we often see that there's already people who are working on the patient in the room, and we want to make sure that those people are well treated. This equipment is available whether or not the patient is already a PUI or COVID positive, in case there's a sense that this patient likely is at higher risk than we initially assumed, and therefore we want this equipment available. The N95 PPE is coming from 2 other locations. It's coming from the resource nurse in the ICU, as well as the anesthesia team is bringing their own. And we really want to minimize providers in the room. So as I'm sure you're all aware, there's a lot more providers in the room previously than we want now, than 5. But we really want 1 code leader, 1 resource nurse, 2 chest compressors, and 1 respiratory therapist at a max. If intubation is required, the anesthesia provider will come and intubate, or a critical care provider. The one major change there, aside from everyone wearing PPE, making sure we have the masks as well as the face shields, is that chest compressions will need to be stopped during the intubation attempt to try and minimize that aerosolization. There is an out-of-room roles. Many of these individuals were in the room before. One thing in particular and important is that there is a recorder who also serves as a communicator. They are wearing full N95 PPE, and they're standing in the doorway, and the doorway is open. They're therefore communicating with the team inside about what they need and helping to pass information back, pass medications and other things back and forth. Outside of the room, there's also an isolation nurse, and that's where the pharmacist, code cart nurse, backup chest compressors, and the surgical resident will be. This is as it's drawn. So you see the code leader is at the foot of the bed, anesthesia if necessary is at the head of the bed, the respiratory therapist, 2 chest compressors, the resource nurse, and then the other team. This one nurse who's sort of in the what's called the warm zone at the open door will also be wearing the N95 PPE. So there were some questions that were sent out to me. I'll take a minute just to run through them. I think I answered some of these questions already. So do it if you do an early vent strategy, don't you just change your denominator? That's certainly possible, but I think given that we're seeing a progressive rapid decline and our need to minimize risk to healthcare providers, this is the decision that we've made. Mortality in ARDS due to COVID-19 is greater in early studies, but this information is changing rapidly. These guidelines are on the MedStar homepage and Starport. Cardiac involvement at this point is unclear. Is there viral myocarditis? Is there a cytokine storm that's developing? We are seeing some cardiogenic shock, and so we're discussing the tracking of mixed venous O2 saturation. How do we mitigate personal risk? So I know the hospitalist teams are focusing on this as well as everyone in the hospital. I think in stable patients who are on the floor, it's one thing. We're thinking about it, with unstable ICU patients. We want to maintain aggressive and guideline-based critical care while also trying to minimize that. But our aggressive critical care requires entering the room more often to evaluate the ventilator, et cetera. So we obviously want to balance those two things. One thing that we can do certainly is try and limit aerosolizing procedures and be aware of those. So minimizing bronchoscopy, for example, making sure that we intubate in a controlled environment, no nebulizers, no non-invasive ventilation, that sort of thing. So will we be able to do a refresher sim lab for intubation skills? I hope that's not necessary. We have PCCM, anesthesia faculty and fellows, anesthesia residents, ER attendings and residents, CRNAs from the OR, all who are trained in intubating. So I would hope we do not come to internal medicine residents intubating. We are seeing cytokine storm for these patients. We've heard of tocilizumab being used, and we've heard of varied success with that. But I think current guidelines are generally recommending against its use because of side effects and unclear about timing. Intubations, non-intubated patients, should they be given Lasix? Can you hear me?
Yeah.
Oh, good. Okay. The general idea is to try and keep patients even to a little dry. Remember, dry lungs are happy lungs. And then some other questions that I think are, don't have an answer. Is there a need for strict glucose control? Should we hold ACEs, ARBs? Should we start a statin in all patients? What about ritonavir, remdesivir, methylprednisone? I don't think we have an answer to that yet. And I think that what we're getting is lots of advice, recommendations, suggestions, and protocols. But Karidi Scheibel out of Emory stated, experimentation outside of a trial or accepted off-label use, however well-meaning, is unethical. And I think, I agree with that to a certain extent. We're getting a lot of different data from a lot of different hospitals, and what we want to do is work together to treat these patients using the same algorithm that is based on CDC guidelines, as well as best practices and trial data when available. And so to that end, I know that different groups at MedStar are working on best practice plans. We are currently working on one for the ICU that encompasses not only therapeutic treatments, but also methods of monitoring patients and best practices from that standpoint. Once that's vetted, that will also be put up on Starport for everybody's use. Okay, finally, a couple frequently updated resources that I've come across that I wanted to share. Lit COVID is great. I check it every day. It's really the PubMed location for all published articles. Brigham and Women's has a COVID protocols that they're working on every day. And then a classmate of mine from medical school, Josh Farkas, has created, he works with mcrit.org. It's being updated daily. Not only does he have one thing specific about COVID-19, but also critical care focus from the emergency room and ICUs on a variety of the different protocols that we're focusing on as well. So I encourage you to take a look at all three of those things. Sorry to go over a little bit. Happy to take any questions if we have any time, or certainly we can reconvene on a different day and continue discussing this.
Hey Dan, I think thanks a lot for talking, and I think the luxury of having Zoom is that people can leave if they have to go do work. I wonder if we can get through a few more questions just to have it in the recording if you've got some time.
Sure.
So one thing that was asked earlier when we were talking about the two different tables in the ARDS protocol in terms of FiO2 matching to the PEEP is how do you decide which table to use, the high or the low?
Right. So generally, the low table has been one that has been more readily accepted. However, some patients will benefit from a higher PEEP. The patients who will benefit from the higher PEEP will be those that when given higher PEEP we will not see that their plateau pressure increases above 30. And so once we try and push the PEEP to a point, and if we see that they will benefit from that higher number without going with the plateau pressure above 30, then we'll start with the high PEEP table.
And then you made a key distinction in the code that you're going to stop compressions during intubation. Something related to that, what happens to an intubated patient that needs CPR? Right.
So a couple things that we're working on this. The most important thing is to do high quality CPR while also protecting our healthcare providers. And healthcare providers are going to be most at risk because CPR is thought to be an aerosolizing procedure. The reason for this is that traditionally we've taken patients off the ventilator and utilized bag mask ventilation with the endotracheal tube in place. We're trying to mitigate the risk of doing that in two ways. One is to evaluate whether or not it is possible to maintain continuous mechanical ventilation while we perform CPR. And continue to use the ventilator and not disconnect to bag mask ventilation. An alternative, and we're going to look into that to determine whether or not the ventilator can handle that. It's unclear at this time whether the ventilator can provide enough pressure to provide breaths while giving chest compressions without alarming and thinking that there's a fault. Alternatively, what we've done thus far is use the bag mask ventilator with a filter called the filter guard, which is a viral filter. And that filter is something that we're using when intubating patients, as well as with bag mask ventilation, as well as with the ventilator itself. So all patients who have COVID positivity who are intubated have an extra filter in the room, so that if they do need to be bagged, if they become hypoxic, if something bad happens, that we can put that filter in line with the endotracheal tube to try and reduce that aerosolizing effect.
And then it sounds like Dr. Reed wants everyone to know that for now, until you guys sort that out, the plan is they should not be taken off the vent if it should happen in the meantime while you're kind of delineating the policy.
Yeah, I think that's fine. I think that's fine. I think we need to confirm that it works. I worry that if we really just need to have a trial, and I think we will within the next couple of days with a simulation. And if it works, then we'll proceed with that. If not, then I'll send out a communication.
And then Dan, I don't know if you have to go, but because I heard that the PCCM group has a lot of other things going on this afternoon.
I'm good.
Do we have a little bit longer, or?
Yeah, of course.
So, one of the questions was about should, if you needed to know plateau pressure, should the resident be reviewed on how to do an inspiratory hold? And I don't know if that's going to be covered in any of these sessions, or is that something best left to the respiratory therapist and just go based on what's on the chart?
Yeah, I think that that it's a great question. We generally want, the respiratory therapists do measure a plateau pressure and chart it in the computer, but we know that it's best to get it ourselves. So the attendings will often go in the room and evaluate that. So I think at this point we can go off what the respiratory therapist is reporting, as well as what the attending and/or fellow obtain from the bedside. But I'm always happy to go over it on the ventilator as to how to do that.
And then you have this complication of cytokine storm being reported. What do we know about the efficacy of further resuscitation after that point?
That's a great question. We do not have an answer there. So it's unclear, and I think it's just too early. I haven't seen reports of successful or, you know, or just number of attempted resuscitations and the success or not of those once a patient has reached the ICU and they are on multiple pressors. In the non-COVID world, if a patient is on multiple pressors, already intubated in the ICU, and undergoes a resuscitation, their chance of survival to hospital discharges is, you know, around 5% or less. And I try and have that frank conversation with families that that we're doing everything we can, including giving many medications that we often consider giving during a code.
It looks like there's a lot still to kind of learn, and one of the things, you know, everyone seems to be following ARDS protocol, but there's some other things being reported. For example, Dr. Cook mentions something to be able to determine who might be able to go with an intermediate tidal volume ventilation to avoid hypercapnia. Is that anything you guys are talking about yet, or for now it's the ARDS protocol?
For now, it's the ARDS protocol. But I think that these patients do seem to have a very similar inflammatory response that's causing the ARDS in their lungs, and that relates to is the fact that their compliance remains not as severely compromised as others who have ARDS, and so it's possible that we may be able to not be as strict with our numbers moving forward. But the one thing that has really shown a substantial mortality benefit in patients who develop ARDS is the low tidal volume ventilation protocol. And although Dr. Cook is suggesting that, and others are suggesting alterations to that protocol, given that there's no, just because of the timing, there's no clear studies that show a benefit or harm, I would hesitate to alter our protocol at this time.
And, you know, the 85 ventilators is an increase, I think, from what we thought we had recently. At that point, you know, hopefully we're never getting over that, but for even the 85, do we worry about the number of respiratory therapists that can cover that?
Absolutely. We worry about a lot of things. So I think that once we get up to a high enough number with ventilators, other issues come into play, not only respiratory therapists, but also the physical plant of the CCC building. Can we run 85 ventilators with oxygen from the amount of oxygen that we have and the amount of pressure that is able to be delivered to each unit? Do we have the power capabilities of running that number of machines as well? So those are things that we would have to, those are bridges we would have to cross if we got to that point. But I suspect that, so I think that while we're hearing reports of limitations of number of ventilators in other hospitals, that might not be where our limitation is.